Welcome. Continue our public health hearing marathon for today. Thank you for being here and joining the Joint Committee on Public Health for this hearing, where we are going to focus on children's health, disease prevention, screening, treatment, and pharmacies. Today's hearing, we will discuss and gather testimony from legislators, advocacy groups, and coalitions, as well as members of the public regarding several bills before the Joint Committee. And as I get going here, I'd like to take a moment to introduce the Senate members of the Joint Committee. Vice Chair Senator Sear, we have Senator Keenan, Senator Kennedy, Senator Lewis, and Senate and Ranking Minority Member Senator Dooner as well. And in the room from the House side, I see Representative Kane, Representative Ayers, Representative Arriga, Representative Reed, and we have Representative Thurber. Thank you for joining us as well and for your service today in our as we try and hear all the bills before the Joint Committee. For context, for those that may be new or returning after a long absence to the hearing sessions, we're in the two-year process here. One that starts with legislation that originates in the House or Senate, all introduced by legislators. Citizens can also present bills through cooperation and collaborations with a legislator. I want to stress that no decisions will be made today about the bills. We're strictly here today to have a public hearing, to gather testimony and input from members of the public and the groups that I mentioned earlier. We want to know your thoughts and feelings and perspectives as we deliberate the bills that the Joint Committee is considering. Following today's proceedings and deliberation of bills, each bill before the committee will be reported out. If reported favorably, the bill will continue through the legislative process, making it to the floor for debate and further consideration by the entire legislature. So once the bill, this is kind of one of the steps in the process after filing and how a bill becomes a law. And so again, sometimes people think this is the be-all, end-all. Today we're here just to accept testimony, oral testimony. You can always submit written testimony as well. If you are speaking, you will have a maximum of 3 minutes to provide oral testimony. For those speaking in panels, we will have a 6-minute total time frame. So if you have 2 people or 3 people, it's still 6 minutes per panel. Please listen carefully for when your name is called, and be prepared to join us at the testimony table here or online if you're participating via Teams. Following your allotted time, committee members will have an opportunity to ask questions. Each speaker has only one opportunity to testify today, so if you're speaking on multiple topics or bills, we ask you to make all your comments within that allotted time. Written testimony can also be submitted at any length via email to my legislative director, Matt Murphy. His email address is matthew.murphy@masenate.gov. If you're joining virtually and it is not your turn to speak, please remember to keep your microphone muted. And again, thank you for being here, and we will get started with some bills. First up, we are hearing H.2413, and I have Cecilia Ducet, Massachusetts for Safe Technology. Welcome.
Thank you. I'm Cecilia Ducet, Director of Massachusetts for Safe Technology and the international nonprofit Safer Screen Time. To frame up the issue with wireless radiation and why we need the MAVEN registry to include electrical sensitivities, I'd like to ask those of you with an iPhone to take it out right now and go into settings. We're going to give you a look at the radiation warning. Feel free to look on with a neighbor if you don't have an iPhone. From settings, a little ways down, hit general, then go all the way down to the bottom and hit legal and regulatory. At the top of the next screen, 4 down, hit RF exposure. The bottom of that first big paragraph says that this device was tested at a distance from the body. So if you're holding it with the antennas radiating, you are exceeding the Federal Communications Commission's limits for public radiation exposure. A couple paragraphs down, they say, to reduce your exposure, basically don't touch something that is radiating. Use a hands-free option. The FCC has now been sued for ignoring 11,000 pages of evidence of harm, and the courts found them guilty. But the FCC has been doing nothing to protect us in the last 4 years. Now I would like to demonstrate this invisible toxin. In the scientific literature, they want us to be at a maximum of 10 microwatts or less. With the wireless access points and everyone's personal devices radiating in here, we are at 1,500. I will leave this meter with Matthew Murphy so you can all measure your own exposures and wait till you see what it does right up against your cell phone. So what does this radiation do? The World Health Organization has just announced high certainty that cell phones cause cancer. This graphic illustrates additional scientific documentation outcomes when we allow our bodies to be exposed to man-made radiofrequency radiation. Insomnia, headaches, brain fog, ringing in the ears, heart palpitations, anxiety, depression, anger, skin problems, DNA damage, ADD, ADHD, autism, Alzheimer's, and more. It is a neurotoxin. Thankfully, we have what you need in this bill's requirements to educate the public. The EMF Medical Conference is here now to train doctors. Our own Massachusetts Breast Cancer Coalition has K through 12 school curriculum on prevention with cell phones and wireless. We have a 1-hour course online at Safer Screen Time to train the public, which I co-developed with one of the world's leading scientists in Finland, Dr. Mikko Ahonen. The ADA has long recognized electromagnetic sensitivity. Now it's your turn. Please include electromagnetic radiation syndrome in MAVEN so we can gather decision-making data to protect all of us, and especially our children, from this new environmental illness. Thank you, and I'd be happy to answer any questions.
Thank you for your testimony. Any questions from the committee? Seeing none, thank you very much. Next, continuing with H.2413, Patricia Burke, Safe Tech International, on the virtual. Do we have Patricia? No. What about Benny? Next up, we have Courtney Gilardi on virtual. Courtney?
Hello, can you hear me?
Yes, go ahead.
Thank you so much. Honorable legislators, thank you for allowing me to express my support for H.2413 and your support on this vitally important piece of legislation. When my daughters and I were diagnosed with electromagnetic sensitivity, also known as EHS, EMS, or microwave illness, I wondered if we were alone. And I quickly learned that the answer was absolutely not. After all, I had never heard of this condition. So I was surprised that when we went public with our story, that so many others reached out to us to share theirs. I discovered an accredited EMF medical conference, medical textbooks and nursing textbooks, public health textbooks, and a medical association position statement on this condition. I learned that there was a Microwave Injured Vets Association and that the U.S. National Council on Disabilities Health Equity Framework includes electromagnetic sensitivity. So does the U.S. Access Board. I was grateful that our Massachusetts public health boards were educated about this condition. Our Massachusetts Department of Public Health page had advice for those concerned. But I was also devastated to learn that there was no registry here in Massachusetts to simply count the number of folks impacted. And this bill corrects that. There is so much misinformation about what EHS is and what it isn't that it can create shame, stigma, and bias that results in confusion and inaction. And this can change, and we can take this action today because of each of you. This bill is not just about counting those with a medical condition. It's about creating a committee to address this problem. It's about disseminating information that can support the residents of Massachusetts by providing them with resources that can help to reduce their symptoms and to create health and wellness, and to connect people to the right support along with the care, compassion, and understanding they deserve. Thank you for your favorable support on H2413 and for learning about EHS. In our written testimony that we'll be sending, we will include science, resources, and additional information that I hope brings an urgency and priority in moving H2413 forward. Thank you.
Thank you. Any questions from committee members? Seeing none. Next, we have Patricia Burke, Safe Tech International, on virtual.
Hi, thank you. Can you hear me?
Yes, go ahead.
Thank you. I'm Patricia Burke from Millis. I work with Safe Tech International, and I'm asking the committee to advance the bill. AI, smart meters, 5G, and data centers are all supposed to support data-based decision-making, but the data has to be collected in the first place. And he who controls the data controls the narrative. As an example, Massachusetts is in the process of installing over 2.9 million digital electric meters while flying blind. Following the San Bruno gas explosion in California in 2010, an administrative law judge ordered emails between PG&E and California's utility regulator to be released to the public. And the emails revealed that 15 years ago, CPUC President Michael Peavy knew that the meters were inflicting harm, but utilities in Texas and California hired consulting firms, Structure and Navigant, to bury the emerging issues. Unfortunately for Massachusetts, National Grid also hired Navigant to spin the results of the Worcester Smart Meter pilot program. The pilot was supposed to determine whether meters were a reasonable investment for ratepayers and not to produce pro-industry marketing. In addition, the Massachusetts Department of Public Utilities relied on the interpretation of a notorious mercenary expert, quote unquote, also working for Philip Morris Cigarettes, to nullify smart meter health risks. Legislators should have 15 years of data at their fingertips about the scope of smart meter injuries nationally, and you have none. Decision makers should also have hard data about the number of Massachusetts residents who've already been harmed from any source of EMF RF or who have health conditions that predispose them to further injury from these meters. You have no data, and you can change that by supporting the MAVEN bill. Thank you so much.
Thank you for your testimony. Any questions from the committee? Thank you. Next, virtually, we have Amelia Coco Gilardi.
Hello, can you hear me okay?
Yes, please go ahead.
Thank you. Esteemed legislators and honorable committee members, my name is Amelia. I am 17 years old, and I would like to thank you in advance for passing House Bill 2413. I testified on the same bill in the last legislative session, and it did not pass, and I am here today to ensure that this year it does, because I am not invisible even though my illness is, and I, like all of those with electrosensitivity, deserve to be counted. I'm testifying today because this is my bill. My state representative, Tricia Farley-Bouvier, introduced it on my behalf because I've suffered and struggled with an environmental illness. In the nearly 5 years that I've been raising awareness of this issue and asking for help, policy changes, and protections, I've met so many people with EHS, so many who cannot be here today, but I have learned that it is critical to give electrosensitivity a voice and the care and attention that this condition deserves. Why is adding EHS to a database of diseases important? Because data drives decisions, and our Commonwealth cannot make common sense health and safety decisions unless there is real-time data behind it. While my pediatrician and osteopathic physician knew about electromagnetic sensitivity and were able to provide my family the American Academy of Physicians position statement, resources, and a treatment plan, not every care provider is knowledgeable about this condition. This bill remedies that issue. Not only does H.2413 add EHS to a database so that each of us can be counted and trends can be reported, it creates a committee of experts to figure this issue out and to ensure all physicians and public health care providers have access to the published diagnostics and treatment guidelines. This is absolutely vital and long overdue, because while my healthcare team knew about EHS, not all do. This creates a devastating disparity in healthcare gap that results in a delayed diagnosis and treatment information and can help prevent this condition from becoming worse. Information on EHS should be easily accessible and provided to all healthcare providers and boards of health. This bill ensures that. Thank you for seeing me, counting me, and voting favorably on H.2413. Thank you.
Thank you, Amelia. Next, we have Janet FitzGerald on virtual. Janet?
Yes. All right. Are you able to hear me?
Yes, please go ahead.
All right, great. Thank you. First of all, I want to just say thank you for allowing us to testify. And I want to say I am humbled by those who have preceded me just now. They have done their homework. They are so articulate. And I'm going to speak more as a patient, an EMF sensitive patient who has gone to several doctors who've never heard of it. And I come in and I have to explain what it is. What is EMF radiation? How am I affected? I bring in this meter, Cece showed you as well, because it's scientifically calibrated to show them that their own office is now in the red zone. So green, yellow, orange, red is one way to look at these meters, right? Instead of just the numbers. And it gets their attention. And I bring in the literature to them, the scientific literature. And I think there's something wrong with this picture. Why am I the patient who's affected by EMF sensitivity with headaches, including tachycardia, a major tachycardia event when I was exposed to 5G? Why should I be explaining this to these doctors? They should be explaining it to me, right? There are some doctors who do know about it, as Amelia has said, and I've been so lucky to have been received services from those doctors, but they're in the minority. And the MAVEN bill 2413, H.2413, will change this problem up so that not only will the EMF sensitivity, and yes, it has several names, but basically I call it radiation saturation. And eventually we're all going to reach it because the sources are increasing exponentially, the sources of EMF radiation. So this is not going to go away, it's only going to grow. This MAVEN bill will not only recognize it, which is a must, not an if, but it's a must, but it will also serve to help educate healthcare providers. I was one of the lucky people who was able to attend the EMF medical conference. I got my CEUs from it because I'm a healthcare professional myself as a speech pathologist. So I got my CEUs. It was a very instructional course. It's now provided free. So this is an easy bill to pass because the information is out there for the doctors, nurses, and all the other healthcare providers. They can learn information about EMF sensitivity. They can better diagnose it and better treat it, rather than having the patients trying to explain it to the doctors. What I'm here for today is to just say, please don't hesitate on this bill. This has to get through quickly. We are suffering. And you are in the position to change that. Thank you.
Thank you for your testimony. Any questions from the committee? Seeing none, thank you. Next we have Kirsten Batty. Kirsten Batty on virtual.
Hi, can you hear me?
Yes, please go ahead.
All right. Hold on, I just had to pull up my screen. All right. My name is Kirsten Batty. I'm director of Latchy Laws Massachusetts, which is working on a petition initiative to reduce electromagnetic exposures and on another to make the state legislature more egalitarian. I'd like to provide support for the testimonies of Karen Spencer and Courtney Gilardi, and also for my own bill, H.2411, an act reducing non-ionizing radiation in early to higher education. So there are decades of evidence of harm from fluoride, from non-ionizing radiation and other toxins. And that's one reason why Robert Kennedy was able to move the dial in support of Trump. So this is the first time that environmental harm has been such a big factor in elections that it's been able to decide the outcome. Now, industry has always suggested that more research is needed, but we know from common sense that our children, they clearly show harm. They are having so many problems. And so it's raising questions in this toxic environment, both socially and physically, about how we can sustain our future, including social security if our kids are in poor health. We also have very high rates of disability, especially among the more sensitive older women as far as electromagnetic exposure. And this is proven in the research. As far as the men go, it's usually from acute conditions at a later time. So the problem is with electromagnetic toxins is that our bodies are actually controlled by electromagnetic exposure. We actually use wireless in our own bodies, so there's interference. So in the bill that I put forward, it's just to provide an option for schools to be able to reduce those exposures. And I know that the public is tired of all the technology being pushed, the technology that has a high environmental cost and also has cost on our social environment. So the people are interested in changing this. Anyone I talk to, and I talk to lots of people, and of those people, I also talk to a lot of people who are in the group I have who are ill. I just talked to a lady the other day that I had talked to for the first time. She had to move out of her house. She's out of her house. Her husband is okay, so he's in the house. And she's gone to move in with her mother. So it's happening to more and more people, and the research shows that it's a quick onset. It happens, it's a surprise for people in the prime of their life, often to the woman, that they become sensitive and they can't feel. So the bill that I put forward, it's very easy to understand, it's all explained, and it's just for the point of to provide a choice, which people do not have.
Thank you.
I'll close my testimony.
Thank you for your testimony. Any questions from the committee? Seeing none, thank you very much. Next, moving on to bills S-1508 and H-2413, both titled An Act Establishing an Amputation Prevention Task Force. I have a panel from the American Diabetes Association, Stephen Hobby and David Alper. Welcome.
Thank you, members of the Public Health Committee. My name is Stephen Hobby. I'm the Vice President for State Government Affairs with the American Diabetes Association. The association supports these two bills, both of which would establish an amputation prevention task force. The group would explore the issue and recommend solutions to lower the incidence of lower limb amputation. So why is this issue of concern to the Diabetes Association? Well, nearly 600,000 adults in Massachusetts have diabetes, or about 1 in 11. It's a chronic disease requiring adequate self-management to preserve one's health. People with diabetes are at risk for serious, potentially disabling, even deadly complications, one of which is lower limb amputation due to circulatory problems and loss of sensation in the foot. In our country, it's estimated a limb is amputated due to diabetes every 3 minutes and 30 seconds. These complications and resulting amputations, not surprisingly, impair quality of life, can affect productivity, and lead to significant additional healthcare costs. We convened with legislators a roundtable at the State House last December, along with clinicians, to explore this issue. That discussion led to this proposal to establish a task force. The task force would take a systematic look at reducing amputations, recommend approaches to encourage collaboration among clinical stakeholders, and ensure access to treatments and services to prevent amputations, including coverage for evidence-supported treatment of diabetic foot ulcers and peripheral arterial disease. The task force would also consider measures to improve and incentivize quality care to avoid amputations. I appreciate the committee's consideration of this important matter and hope you will support these bills. Thank you.
Well, we have been sitting here this afternoon so far. There have been 7 amputations in this country due to diabetes and circulation changes. What's even more horrific is that 6 of these 7 are people of color. A person of color is 4 times as likely to have an amputation due to this disease. A person of Latino descent, 1.5 times. We also know that 50% of these people will be dead within 5 years of their amputation. We're talking limbs and lives here. And the most horrific statement, the most horrific statistic, is that 85% of these amputations are preventable with early intervention. And that's what we are looking for. Senators and Representatives, my name is Dr. David Alper. I'm a podiatrist. I represent the American Diabetes Association, the Mass Foot and Ankle Society, the American Podiatric Medical Association, as well as the Peripheral Arterial Disease and the Clinical Limb Ischemia Society. The reason I mention all this alphabet soup is that this is something that cuts a wide swath in the stakeholders of the medical community. We are trying to get in early and often. And we need the resources, the power, the penetration of the state through a task force to educate the public of what is truly a silent disease. Patients don't know it. They don't know to look for it. And unfortunately, so many of our medical community, of our primary physicians, do not as well. How often do you go to the doctor and you put on that wonderful robe and you leave your socks on? They're not looking down. They're not looking until we reach stage 3 or stage 4 when these symptoms occur. We need to educate the medical community. We need to educate the public to be looking. And we need to get the carriers to have a huge paradigm shift and stop paying for reactive medication and medical care and paying for proactive. I have never had a bill I've submitted for a $50,000 amputation, never even gets questioned. I cannot get a $100 annual diabetic foot exam covered. That is absurd. And you want to talk about healthcare dollars savings, I can do 500 of these exams for 1 amputation. It just doesn't make sense. My patient Michael came to me several years ago with what turned out to be 3rd-degree burns on the bottoms of his feet. And the story was simple. It was a hot July day. He took his family to Revere Beach, and he was the hero that carried everything from the car to the sand multiple times. He had diabetes and was unaware of it. He had diabetic neuropathy, which doesn't hurt, a loss of sensation. He was unaware of it. He came to me with these 3rd-degree burns. We had to amputate 4 toes. 6 months later, we took his foot. I don't know where he is past then. Completely preventable. So again, we ask, this task force will help my colleagues in the medical community make and raise awareness to the public, will help us go to the carriers to get the proper coverage for the simple exams that can be performed in an office. Educate the public to be able to look themselves at changes that will alert them to the fact that they may be susceptible to this type of condition. I will say it again. 50% of people with amputations die within 5 years. 85% of these amputations are preventable with early intervention. You can help us with this by putting the force and the penetration of the state government with us to reach the public. I'll be happy to entertain any questions, and I thank you for your time.
Thank you for your testimony. Any questions from the committee members? Thank you very much.
Thank you very much.
Next, I'd like to welcome Rep. Schwarz.
Thank you very much, Mr. Chairman and Madam Chairman. Is this on? I'm Greg Schwarz. Thank you so much for letting me just spend a couple of your minutes speaking about a bill of mine that's H.2413. This is an act establishing an naloxone purchase trust fund. as some of you may know, in addition to being a first-term state representative, I'm also a primary care physician. I do take a look at people's feet, but usually with my gloves on. What I've just passed around is what you are very much familiar with, I'm sure, on this committee, a package of naloxone, Narcan. And, in medicine, there's few things that are as effective as Narcan. We are always looking for meds, treatments that will move the needle a little bit, whether it's on diabetes care or cardiac care or cancer. And we're very happy when we have something that might make a 5% change or a 10% change. You guys are probably familiar with statin medications like Lipitor. Those make a 30% change. But something like Narcan, which is what you have in your hands there, is a life-saving medicine. It can reverse an overdose and prevent death. And so I know this committee is very familiar with the value of Narcan. It's been a key in reducing some of the terrible outcomes of our opioid epidemic. And I know last session you were instrumental in passing the substance abuse bill, which included in it a provision that required the coverage of Narcan by commercial insurance, which is terrific. The reason for my bill, which would set up a trust fund to help hospitals and other clinics pay for providing Narcan free of charge to their patients, is because the emergency room doctors that I've talked to have come to me and told me that the provision that provides the insurance-covered Narcan is not really working for their patients. When they have a patient that comes in with an overdose or a near overdose and they want to send that patient out safely, they do not feel that just giving them a prescription for Narcan is going to do the trick, because that patient may, first of all, not get to the pharmacy to actually do it, to get that medication, that life-saving medication, but also because the medication should not only be in the patient's hands, it needs to be in the hands of the family and folks around that patient in case that patient does end up with an overdose. So what they end up doing is they provide the Narcan gratis on the way out. And they are looking for a way to do that more economically and to do it in a way that doesn't put their bottom line in trouble. And so what this bill would do is would create a purchase trust fund within DPH that would be able to enable them to buy in bulk and have all the savings from that. And so I encourage you to look at this bill. I hope that it meets with your approval and can move forward. And I would be remiss if I didn't mention that our colleague, Kate Donahue, who has been a leader in this space, unfortunately because of her personal tragedy of losing a child to overdose, is a co-presenter on this bill with me. And she also asked me just to briefly mention that her bill, which is also before you today, H.2413, which would basically ask all bureaus and commissions and departments to have at least a small supply of Narcan in their possession, kind of like an automated emergency defibrillator like we have in all these places, is also before you, and could you take a look at that as well? So thank you for your attention. Thank you for giving me the time, and I apologize I went over.
Thank you, Representative. Any questions from the committee? Thank you very much.
Oh, and I'm going to need my Narcan back.
Thank you. There you go. Next, we have Sarah Rose Sald, Massachusetts General Hospital, on virtual. We'll move to Anita Dua, Massachusetts General Hospital, on virtual. No. I may not get this name right. How Pham on virtual. H-A-U Pham. How Pham. We can see you on the virtual screen. Are you able to testify this time? We will come back. Tyler Silverman, Massachusetts Foot and Ankle Society, on virtual.
Yeah, can you see me?
Yes, Tyler, go ahead, thank you.
Okay. Thank you, Chair Decker, Chair Driscoll, members of the committee for letting me testify on this. Thank you for the opportunity to testify in strong support of House Bill 2433, Senate Bill 1508. I know Dr. Dua and Rosal, they're both very busy surgeons at Mass General Hospital. Dr. Dua is a vascular surgeon who I've met with multiple times in the center of patients. Dr. Rosal is a podiatrist. And they would wholeheartedly support this because limb salvage is a team approach. I'm a podiatrist at South Shore Hospital, where I work at an outpatient podiatry clinic treating regular issues, but I also spend about half my time at the wound care center at the hospital. At the wound care center, I treat patients with lower extremity wounds at risk for amputation. The majority of these wounds are related to diabetes. However, some come from trauma and some come from tobacco and alcohol misuse. I work with my patients to help prevent major amputations, meaning amputation of the foot, through offloading, casting, wound care, stem cells, and reconstructive surgery. I work with the team there. My team often rounds as a group together. We work with vascular surgeons, plastic surgeons, primary care, endocrinologists, infectious disease, and have our own, I guess you could say, mini task force at the hospital trying to help prevent major amputations and healing these patients. The collaboration of multiple different specialties and areas of expertise is essential for preventing amputation. As Dr. Alpert pointed out, the mortality rate after a major amputation at 5 years is 50%. If we're all very well educated on cancers, we wear sunscreen, we perform our own cancer exams, you go to the primary care, that's a devastating diagnosis, but the mortality rate from a major amputation is worse than most cancers. And the public awareness, as Dr. Albert pointed out, is much less. Most of you probably wear sunscreen to help prevent skin cancer, but don't check your feet regularly to see if you have a diabetic foot wound or symptoms of diabetes. This legislature brings together stakeholders from across healthcare, government, and community organizations, including medical experts such as endocrinologists, vascular surgeons, diabetic educators, and podiatrists, primary care, and policymakers. With a focus on early detection, wound care access, patient education, this task force can make recommendations that promote timely, cost-effective intervention that save limbs and lives. If we get to these issues sooner rather than later, we can keep people out of the hospital, save a lot of money, and save a lot of lives. This task force will help also develop strategies to address disparities in access to health care and outcomes. As been pointed out, minorities, Latinos, Black Americans are significantly more likely to suffer a major amputation. By implementing best management outcomes, this task force can help work together to take steps to help prevent major amputations. And I am representing the Massachusetts Foot and Ankle Society. I am their legislative chair and vice president. Thank you for your time.
Thank you for your testimony. Any questions from the committee? Seeing none, thank you very much. Next, we're going to switch to SB 1603, Kevin Flanagan. 1603 is an act to conduct a public health study of synthetic drugs in the Commonwealth. Welcome.
Good afternoon, Chairs Driscoll and Decker, members of the committee. My name is Kevin Flanagan, and I serve as the legislative representative for Mass Correction Officers Federated Union. I'm joined here with the president of McCufu, Dennis Martin. We represent approximately 3,000 correctional professionals across the Commonwealth. I'm here today to express our strong support for Senate Bill 1603, an act to conduct a public health study of synthetic drugs in the Commonwealth. The use of synthetic drugs, particularly K2, within our prisons and jails has reached a critical level. These substances pose serious health risks to both inmates and correctional staff. Inmates under the influence of synthetic drugs often exhibit extreme and violent behavior, sometimes appearing to have superhuman strength or become completely unresponsive. Even more concerning is the impact on correctional officers and staff who are exposed to these substances secondhand. Many have experienced sudden loss of consciousness, severe disorientation, often requiring the administration of Narcan, which does not work with synthetic marijuana, in emergency transport to hospitals for further evaluation. These synthetic drugs are incredibly difficult to detect, especially because they are often mixed with common household products like bleach, Raid, or Pledge. This not only complicates the detection and prosecution, but also exposes staff to dangerous carcinogens that could have long-term health consequences. Senate Bill 1603 will empower the Department of Public Health to conduct a comprehensive study into the prevalence, composition, and health impacts of synthetic drugs. We urge this committee to ensure this study includes the Department of Correction facilities where the effects are acutely felt and solutions are strongly needed. We believe such a study will help identify prevention strategies, improve detection methods, and ultimately hold those responsible for the introduction and use of these substances accountable. I respectfully urge this committee to report out Senate Bill 1603 favorably. Thank you for your time and consideration.
Thank you for your testimony. Any questions from the committee? Seeing none, thank you very much.
Thank you.
Next, moving to Bill H.2548, an act banning artificial fluoridation schemes. I have Dr. Abe Abdul, Massachusetts Dental Society. Dr. Abdul will come back. Next, moving to S1517. I have a panel, Massachusetts Dental Society, here in person, Dr. Francis Claremont, Dr. Arnold Weiss, and Dr. Kay Thomas. Welcome.
Esteemed members of the Joint Committee of Public Health, thank you for this opportunity to address an issue of profound importance to the health and well-being of our communities. I am Dr. Francis Claremont and Chair of Mass Dental Society's Committee of Government Affairs. We are in opposition to Senate Bill 1517 and House Bill 2548, which, if passed, will ban municipal water fluoridation in the state of Massachusetts. Municipal water fluoridation has been a cornerstone of public health for decades. Today, the testimony of our panel representing the Massachusetts Dental Society is grounded in scientific evidence, decades of research, and the undeniable benefits that fluoridation has provided to millions of people. Even the CDC has recognized it as one of the top 10 great public health achievements of the 20th century. I have been practicing long enough to have witnessed firsthand the adverse effects of non-fluoridated water in Boston, as well as the benefits of fluoridated water. As both a resident of the Brigham and Women's Hospital and the section chief and director of ambulatory dental services at Kearney Hospital, I routinely witnessed young children with rampant decay in both permanent dentition, primary dentition. In addition, I commonly saw and treated serious large head and neck infections in both adults and children resulting from abscessed teeth, where in some cases were even life-threatening. The pain and suffering resulting from rotting dentition was great, primarily impacting our most vulnerable and underserved populations in Massachusetts. 10 years after water fluoridation had got its foothold in the community, it was common for me to find no decay in my patients on routine exam, even though the dynamics of the given population had not changed other than water fluoridation. Witnessing the benefits of water fluoridation firsthand was beyond words amazing to me. The evidence overwhelmingly supports the continuation of water fluoridation as a safe, effective, and cost-efficient public health measure. Its benefits extend to everyone, regardless of age, income, and background. Banning water fluoridation would reverse decades of progress and would impose significant health and economic costs. I urge members of the Joint Committee of Public Health to carefully consider the scientific evidence and the far-reaching implications of a decision to ban fluoride. Thank you.
Hello, thank you for letting me speak today. My name is Arnie Weiss, a pediatric dentist of 45 years from Brookline, Massachusetts, speaking on behalf of the Mass Dental Society, Alliance of Independent Dentists, Mass Academy of Pediatric Dentistry, and personally for the children of the Commonwealth. I'm one of the few remaining dentists that have been practicing before fluoridation. When I started practicing pediatric dentistry in the Brookline, Boston area, there was no fluoride in the water system. I had children 2, 3 years old coming in with 12, 14 teeth, badly decayed down to the gum line. Many of them, 2 and 3 years old, needed to be done under general anesthesia. Kids in their teens would be coming in with permanent molars broken down to the gum line and half-moon decay on all the front teeth. You know, without fluoride, even with fluoride, there's still some decay. After these teeth are restored, eventually the kids even had more decay without fluoride. After the fluoride was added to the water in the 70s, basically the caries rate significantly went down and was more controllable. It's the most common childhood disease, and water fluoridation minimizes it. Calgary, Canada removed fluoride from the water system in 2011, and they found that the caries rate rose so high that was an increase of emergency room visits for dental procedures 700%. And as of this year, they're reinstituting water fluoridation. There's no credible peer review evidence that shows water fluoridation is ineffective or unsafe. And a recent study by Harvard and Mass General shows that the pain, suffering, and cost over 10 years would be $20 billion of increased treatment. I respectfully ask the committee to vote against this bill that is attempting to remove fluoride from the water system for the sake of the citizens of the Commonwealth and the children.
Hi, I'll speak quickly. Thank you for your opportunity to speak before you. My name's Kay Keating. I'm a dentist, and I came here to speak in strong opposition to the bill to ban fluoride. Fluoride reduces tooth decay by at least 25%, both in children and adults. That's something that I want to talk to you about because nobody else is addressing the adults in the room. And adults, as we age, are also benefiting from fluoride. We have a rapidly aging population with older adults, and as I treated older adults, that's my bailiwick. Fluoride is safe. Fluoride levels are carefully maintained at 7.7 parts per million, and it's proven safe, effective, and over 7 decades of research. As the saying goes, the dose makes the poison. Many substances essential to life can be harmful if consumed in excessive amounts. For example, too much oxygen can cause damage to the lungs. Too much water, which we think is great to drink, can be problematic at high volumes. Can make your heart stop, and it can make you drown. Fluoride is no different. At carefully controlled levels used in community water fluoridation, it is safe to provide clear protective benefits to teeth. Community fluoridation is water fluoridation is especially important to promoting equity. It benefits people across all socioeconomic backgrounds and ages. According to those with limited access to dental care, including those with limited access to dental care, or fluoride products like toothpaste.
Thank you.
As the ADA, stop.
Yeah. We invite you to submit written testimony as well, and any of the data that you want to submit as well.
Thank you for your time.
The question?
No, just Dr. Weiss, you were both of my kids' first dentist. So it's lovely to have you here.
Where's my brother, Mr. Keating?
Two other people who in the house here that.
And you take patients earlier, at least then, than a lot of other dentists did, which is why we travel all the way from Cambridge to come see you. But thank you you were the best play date they ever had, and you made going to the dentist a really easy experience. So thank you.
Thanks. It's been my honor.
Any questions from committee? Seeing none.
If
Thank you.
anyone does have any questions, contact myself or anyone else, please. I'm welcome to help the children. Thank you.
Yes.
Very much. Next, we have Karen Spencer. Karen? Welcome.
Thank you. I'm Karen Spencer, a resident of Leominster. I support the fluoride ban bill and the fluoride warning bill. My family and I suffered permanent harm due to optimal fluoridation, begun during my second pregnancy in 1981. I am a member of the Food and Water Watch, identified as fluoride poisoned in its TSCA lawsuit against the EPA, which resulted in a favorable verdict in September of 2024. After 18 days of expert testimony, Judge Chen wrote, "The court finds that fluoridation of water at 0.7 milligrams per liter, the level presently considered optimal in the United States, poses an unreasonable risk of reduced IQ in children." He also wrote that the scientific literature in record provides a high level of certainty that a hazard is present, and that in every scenario utilizing any of the various possible points of departures, exposure levels, and metrics, a risk is present. The size of the affected population is vast. Although dozens of communities with local control over fluoridation ended fluoridation prior to this verdict, many more have taken a fresh look at the fluoridation practice since the ruling. Utah and Florida are the first two states to enact bans, while about 20 other states and close to 200 communities have either ended or are considering ending fluoridation. Even the FDA, which does not have authority over drinking water, has initiated action to remove fluoride supplements from the market, and IQ isn't even their first reason. Despite the disingenuous claims from fluoridationists, fluoride has never been found to be safe for consumption. The FDA listed failure to be certified as safe as their first reason for ending the controlled dosing of children. The next three FDA reasons should make this committee's blood run cold. Fluoride consumption damages the gut microbiome, which in turn affects immune function, interferes with thyroid hormones, increasing the risk of obesity and kidney disease, is associated with neurological deficits such as more learning disabilities, emotional dysregulation, sleep disturbances, and anxiety and depression. And if that isn't enough, at least 50% of the fluoride consumed is stored in bones, where it has a half-life of 20 years. Fluoride is an inflammatory that can cause or worsen arthritis and make bones more brittle. I will not live long enough to purge my bones of its fluoride load. Neither will I be able to undo the damage done to my child. This is the third time I've testified on fluoride legislation. Ban fluoridation or give residents home rule authority to end fluoridation without requiring a special act. More information can be found at www.fluoridelawsuit.com. Peer-reviewed, published science. Thank you. I'm delighted to answer any questions.
Thank you for your testimony. Any questions from the committee? Seeing none, thank you. Lisa Ataviano?
I'm here.
Virtually?
Can you hear me?
Yes, please go ahead.
I'm testifying in support of bills S1517, H2548, S1518, H2549, S1630, and S1575, H2249. I have well water, but if I had fluoridated water, I would be exceptionally concerned about protecting myself and my family from it. I am meticulously careful about avoiding toxins. I have a giant garden and grow as much of my fruits, vegetables, and mushrooms as I can. However, there is no way for me to know if the food I purchase has been grown with fluoridated water. Food grown with fluoridated water can legally still have an organic label. The fluoride added to our water supplies is a toxic industrial waste product of the phosphate fertilizer industry. Industry convinced municipalities to incorporate it into the water supply so they did not have to pay to dispose of it properly. What is good for industry rarely overlaps with what is good for human health. If fluoride has any benefits at all, which is questionable according to reams of studies, it is when it is administered topically to teeth, not ingested. And even if it has any benefit for teeth, it is neurotoxic, and scores of studies have shown it can cause a slew of health problems such as dental and bone fluorosis, emotional, behavioral, and cognitive deficits, organ damage, strokes, and immunotoxicity. How many of you are willing to give up your health to possibly prevent one cavity? There is a growing trend towards removing fluoride from the water supply. Massachusetts always prides itself on being a cutting-edge leader. Does Massachusetts want to be on the front end of the trend and protect its residents, or wait until the bitter end to remove fluoride? We will someday look back on water fluoridation in the same way we look back on using mercury to treat felt in the hat industry, using radium to illuminate watch dials,
using x-rays at the shoe store to determine if shoes fit children's feet properly, or using DDT inside to kill carpet beetles. All of these things happened in the United States in the not so distant past during my parents' or grandparents' lifetimes. Please vote these bills out of committee favorably. I'm also in support of Bill H.2413 about adding the electromagnetic sensitivity disorder to the MAVEN report. I was unaware that that was in this hearing, so I didn't sign up to testify, but I'll send written testimony. And I'm going to include a chart from the Bio Initiative. It's got hundreds of studies. You can easily skim through it. There's a sentence or two describing each study about electro or radio frequency waves, EMF, Wi-Fi, smart meters, all of that. You can skim through the whole thing in probably 10 minutes or so, and it'll give you a good overview of the risks involved. Thank you so much for your time.
Thank you. Any questions from committee members? Seeing none. Next, virtually, we have Jessica McGovern. Jessica?
Can you hear me?
Yes, please go ahead.
Hi. I didn't write anything down. I just want to comment briefly on banning the fluoride. I was curious about it, so I went to my local water department and asked to look at the bags, and they're big 50-pound bags he rolled out on the cart. I couldn't touch it. But on it were skull and bones and the word poison all over the bag. So to me, it was common sense. This is not a mineral, it's a poison. And there's 3 counties in Massachusetts that don't add fluoride. They never have. The entire Cape, Berkshire County, and I also believe Franklin County. And I don't think, I've never heard of a public health crisis or concern of rampant cavities in any of those counties. And, you know, it's determined at federal court. It was a 7-year lawsuit that it's a neurotoxin. I mean, how much more evidence do we need? And why is the EPA ignoring this? I suspect pretty soon, though, I've heard from about Lieseld and Kennedy that they will take some action to ban it. Also, the bill H.2413 about safe tech, it would be wonderful if they can have a diagnosis for the radiation poisoning, which affected me at work. I looked at someone's 5G phone and I could actually feel the radiation going right into my forehead, and I nearly fell over. I had vertigo just instantly. And then it started to affect my heart and my pressure. So I had to quit my job and heal, and now my whole house is mitigated. I never thought it would have happened to me. And so it's cost thousands of dollars because not that many people know about it and how to treat it. Thank you for your time.
Thank you. Any questions from the committee? Seeing none, thank you. Next, Dr. John P. Fisher, Better Oral Health for Massachusetts Coalition and Massachusetts Dental Society. Welcome.
Good afternoon. Thank you for allowing me to speak. I speak in opposition to Senate Bill 1517 and House Bill 2548. I'm a past president of the Massachusetts Dental Society. I'm the past chair of the Better Oral Health for Massachusetts Coalition. I currently serve as a board member of the Better Oral Health for Massachusetts Coalition. I serve on the Special Commission on Oral Health for the Commonwealth of Massachusetts. I'm an advisory member of the Mass Medical Society Oral Health Committee. I'm a member of the Oral Health Advisory Task Force, Healthcare for All. I'm a member of the advisory board for the Forsyth School of Dental Hygiene. I'm the chair of the MDS Task Force on Access, Prevention, and Interprofessional Relations. The current conversation about optimal community water fluoridation, and I stress optimal, is often framed around government overreach, personal choice, and public health policy. What is an ideological discussion for those of us who have access to and can afford dental care is a real-life consequence for those who do not share those options. Food stamps do not allow for the purchase of toothbrushes, toothpaste, or fluoride rinses. A shared toothbrush is not an experience many of us will ever have to endure, yet it is not a rare occurrence among the poor. My wife and I, volunteering in a mobile access to care van doing free dentistry for poor children, encountered many who never had their own toothbrush, only having a family toothbrush or one they shared with their siblings. We saw devastating decay in non-fluoridated communities. In many ways, optimal community water fluoridation remains the only preventive dental measure that reaches those vulnerable populations who lack regular access to care, the most marginalized in our community. There are no current credible peer-reviewed scientific studies in the United States that prove without a doubt that optimal community water fluoridation is anything but safe, effective, and cost-efficient. And cost-efficient is a key part of the equation. Any number of recent studies have noted increased costs of billions of dollars to the government if fluoride is no longer available to those most in need. If fluoride is banned from community water, there must be an equitable alternative that will supplement this very important health provision, a health policy that has been considered one of the top 10 public health initiatives of the 20th century, alongside antibiotics and vaccinations. We have forgotten, never knew, or have chosen to ignore the poor oral health and poor systemic health that was a way of life when vaccinations, antibiotics, and optimal community water fluoridation were first introduced. We must not fall prey to pseudoscience and misinformation. We must base our decisions on fact, equity, and empathy. We must not allow public health policy to be shaped by those with the loudest voices at the expense of those with the greatest need. I have not addressed the specifics of the effectiveness, safety, or cost efficiency of optimal community water fluoridation, but I lecture on optimal community water fluoridation and would be happy to answer any specific questions you might have. I have no conflicts of interest, nor am I compensated for being here today.
Thank you, Doctor. I got nervous when you read your distinguished resume that you'd be over time, but thank you for staying on the time. Appreciate you.
I practiced it before I came in. I wanted to do it 3 minutes right on the button.
Any questions from community members? Seeing none, thank you very much.
All right, thank you.
Next, we have Deirdre Healy. Deirdre, welcome.
Good afternoon, Public Health Committee. I am here in support of S1517, H2548, S1518, H2549, S1630, and 1575. My name is Deirdre Healy. I am a lifelong Democrat, environmentalist, and resident of Worcester. Worcester has never been fluoridated, and our teeth in Worcester are fine. I was involved in the last 2 ballot question committees that successfully kept Worcester's water safe from toxic fluoridation. The second largest city in New England voted against fluoridation 4 times altogether, and for good reason. Fluoride is a prescription drug. It provides little, if any, benefit, and fluoride in drinking water has been found to be harmful to people, animals, and the ecosystem at the level added to the public water supplies. Fluoride for ingestion purposes is only available as a prescription. A liter of fluoridated water contains the same dose of fluoride as the prescription medicine. Adding a prescription medication to the public drinking water violates our right to avoid medical treatment. When it comes to medication in drinking water, there is no dosage control and no concern for individuals with allergies or contraindications. There is not even a current requirement that people be directly informed that their water is fluoridated. Despite the claims of dentistry, the evidence suggests that there is little, if any, benefit from water fluoridation. The Cochrane Review has examined the evidence for the effectiveness of fluoridation in the decades since the widespread adoption of topically applied fluoridated toothpaste and concluded any benefit is vanishingly small, or there may be no benefit at all. Why does dentistry keep promoting it? To maintain it has concern for low-income residents, while distracting our attention from the fact that the vast majority of dentists refuse to treat poor people, Medicaid patients, in their practices. Most importantly, the last year has seen the National Toxicology Program conclude that prenatal and early life exposure to fluoride in drinking water at a level that is just twice the amount that is added to water is consistently associated with reduced IQ scores in children. This has changed thinking about water fluoridation, and in a historical lawsuit under the Toxic Substances Control Act, a federal judge has ruled that fluoride in drinking water at the level that is currently added, that's 0.7 milligrams per liter, poses an unreasonable risk to the health of children. These 3 bills will restore Massachusetts citizens' rights to avoid harmful chemotherapeutic treatment. Thank you for your consideration.
Thank you. Any questions from committee members? Seeing none, thank you very much. Next, we have Julie Boras, Health Rights MA, on virtual. Julie?
Hi, can you hear me?
Yes, go ahead.
Okay, I turned my camera on. I don't know. I can't see me, but that's okay. Hello, thank you to the committee. My name is Julie Boras. I am one of the founders of Health Rights Massachusetts, and I'm here to testify in support of the numerous bills that aim to allow Massachusetts cities and towns to opt out of water fluoridation. I urge you to support S1517, H2548, or S1630, S1575, and H2449. About 10 years ago, I had a pretty serious health scare, and it turned out to be related to my thyroid. The first thing my doctor asked me, do you have fluoride in your water? I said yes. She said, get it out immediately, and I did, and I guess it worked. I'm still here today, and I didn't take any prescription medication. I learned a lot about fluoride. It's a neurotoxin. It harms brains, bones, and your thyroid, and is especially harmful to developing fetuses and babies. I had to put in an expensive filtration system in my house and under my sink with filters that need regular replacement, another ongoing expense. Not everyone can afford these systems necessary to filter fluoride, especially in the current economy, in a state with some of the highest taxes in the country, where regular people are struggling to pay their energy bills, their mortgage, rent, gas, and groceries. Fluoride is a medication being forced upon people, often against their will, without their knowledge and without being warned of the harms. It's a known neurotoxin, yet we are intentionally adding a toxin to our water supply. A water supply that already has so many other toxic contaminants. If people want fluoride, it is certainly available to them for topical use in everyday products like toothpaste. In my hometown of Shrewsbury, residents have tried for several years on more than one occasion to stop the addition of fluoride to our water to no avail. And one of the reasons for that is there's no clear path to remove it. The current laws and local ordinances related to fluoride are unclear and conflicting. The boards all seem to pass the buck to one another. No one seems sure who is responsible or has the authority to end the practice. S1630, S1575, and H2499 would at least fix that problem. If we really want to improve public health, we should stop the practice of water fluoridation and immediately divert any state money, resources, and jobs towards stopping toxins from getting added into our water and ways to get it out, such as the PFAS filtration program that was recently enacted. Let's focus our energy on that. Fluoridation is a big mistake. It's time for Massachusetts to put a ban on water fluoridation, or at least allow Massachusetts cities and towns a path to opt out. Thank you for your time today.
Thank you. Any questions from the committee? Seeing none. Next, we have Rick North. Rick, welcome.
Hello. My name is Rick North. I'm the former CEO of the Oregon American Cancer Society and former Safe Food Director of the Oregon Physicians for Social Responsibility. After retiring, I moved to Wellesley to be near family. I'm asking you to support SB 1517, HB 2548 to disallow water fluoridation and other bills opposing it. Like many of you, I once supported it. All I'd heard was it was, quote, safe and effective. But when I looked at the science, I discovered it was neither. Based on a wealth of published studies, I changed my mind. It's such a serious risk that I volunteered for the past 14 years with a large group of scientists, physicians, and dentists all over the country to oppose it. You've heard the claim that fluoridation was one of the top 10 health achievements of the 20th century. Actually, it's one of the most widely rejected practices in the world. Out of 196 nations, only 24 have any fluoridation. 95% of the world drinks unfluoridated water. In Europe, only 4 out of 48 countries have any, 2% of the population, and many nations have banned it, including France, Germany, Netherlands, Norway, and Sweden. The National Toxicology Program, the highest level review in the country, reported last August that water fluoridated at 1.5 milligrams per liter is consistently linked to lower IQs, mainly through ingestion by pregnant women and infants. Water is fluoridated at 0.7 milligrams per liter. Since 1.5 is twice as high as 0.7, fluoridation supporters say it's no risk. Please don't be fooled. 2 liters of water at 0.7 milligrams per liter give you about the same amount of fluoride as 1 liter at 1.5. And thousands of people drink 2 liters of water or more per day. In fact, the American College of Obstetricians and Gynecologists recommends pregnant women drink at least 1.9 liters of water a day. But it's far more than that. Only 50 to 60% of fluoride is typically consumed from water. 20 to 30% would be from food and drinks processed with fluoridated water. We're being overdosed with fluoride. And as you've heard, and this is true, the dose makes the poison. A federal court ruled last September, as you've heard, based solely on the science, that fluoridation, quote, poses an unreasonable risk of reduced IQ in children. The most recent, highest quality studies show that ingested fluoride has little or no effectiveness. But even if it were 2 or 3 times more effective, it cannot justify increasing the risk of irreversible brain damage. Please end fluoridation and protect pregnant women and their children. Thank you.
Thank you. Any questions from the committee? Seeing none, thank you very much. Next, we have James Brownell on virtual. James Brownell. All right. Moving on to S-1630, an act relative to opting out of fluoridation. Holly Crosby on virtual.
Hi, can you hear me?
Yes, go ahead.
Hi, my name is Holly Crosby. I'm a mother of 3 children in Marblehead. I'm testifying today in favor of all the bills that steer us toward removal of fluoride from our water systems. I understand there are 4 in the Senate and 2 in the House. First off, all fluoride chemicals we add to water are contaminated with arsenic and other toxins like aluminum, barium, and cadmium. It was found that the incidence of cavities was reduced when fluoride was added to our water supply years ago. I have since heard that those studies were fraudulent, but at the same time, we went from only going to the dentist when we had a problem to twice-a-year cleanings. Also, at the same time, there were major improvements in the toothbrush. Other countries who did not add fluoride to their water saw the same reduction in cavities at that time. Studies that are years old have shown that fluoride causes cancer and reduces IQ in rats. More recent studies have shown that it lowers IQ in children. How can Dr. Weiss and Dr. Fisher, in their testimonies just a few minutes ago, state that there are no studies showing the dangers of fluoride? This is just not true. Why are they lying? What incentive do they have? Fluoride builds up over time in the pineal gland in the brain. Dr. Thomas referred to other substances that are safe at low levels, i.e. oxygen, that are not safe at high. Fluoride builds up over time in the system, so this is not an accurate comparison. What I really want to focus on is this. If I were there in person, I would ask everyone to raise your hand if you or someone you know has thyroid disease. I myself am hypothyroid. My mother suffers greatly from Hashimoto's. I know countless people with thyroid disease. How can this be perceived as normal? How can we not question this? I recently found a study in the National Library of Medicine, aka PubMed, titled, "Does Fluoride Exposure Affect Thyroid Function?" A systematic review and dose-response meta-analysis. The results, quote, overall exposure to high fluoride drinking water appears to affect thyroid function and increase TSH release in children, starting above a threshold of exposure and to increase the risk of thyroid diseases. Another study I found in Scientific Reports, impact of drinking water fluoride on human thyroid hormones, a case control study. The major finding of this study is that, quote, TSH values are higher with a higher fluoride concentration in the drinking water. I've spent upwards of $10,000 for a whole house water filtration system in my home. I have since had the water tested and there's no fluoride coming through. My children have not been exposed to fluoride for 10 years and have never had a cavity. I also want to make one note regarding the EMFs for Bill 2413 and commend Cece Doucette for her testimony. I want to specifically mention the dangers of Wi-Fi. My son had horrible migraines for years until we removed Wi-Fi from our home, and that was 10 years ago. He hasn't had a migraine since. Please pass this bill favorably as well. Thank you for your time.
Thank you. Any questions from committee members? Seeing none, thank you. Next, we have Melissa Braga on virtual. Melissa? Nope. Dr. Mary Kelly Sutton on virtual.
Can you hear me?
Yes, go ahead.
Thank you. Fluoride is in community water supply to decrease teeth cavities for children whose teeth are developing. The proportion of that water that actually reaches this population is only 0.2%. So 99.98% of the water is reaching non-target areas used for car washes, lawns, agriculture, livestock, and adult consumption. This is poor efficiency for a policy and wasteful financially. Where else is fluoride found besides our water? Everyday products, such as aerosols including asthma medications, Teflon, Freon, Gore-Tex, plastics, rubber, concrete, aluminum, nickel, iron, and the less frequent atom bombs, nerve gases, and the common fluorescent lights, engine exhaust, foam insulation, and drugs such as anesthetics, steroids, antipsychotics, anti-cancer drugs, diet drugs, digestive support, a statin, Celebrex and Vioxx, Prozac-type drugs, some foods and teas. Perfect teeth are not as important to a child as his or her full human potential through having full IQ. There are many factors supporting healthy tooth enamel: less sugar, adequate minerals including magnesium and copper and calcium, and real vitamin A, retinol. The dentist Weston Price documented the value of nutrition for dentition in the early 20th century. In the 18th century, the nickname for fluoride was devil's poison because it kills and maims secretly across all life forms. Air pollution with fluoride has resulted in more lawsuits and more damage to domestic animals than any other air pollutant, according to the USDA. It kills and inhibits all forms of life, so it is a rodenticide, an insecticide, and a wood preservative. This picture of reactivity and damage to all living groups is understood in the chemistry of fluoride. Fluoride is the most reactive element on Earth. Fluoride makes the strongest hydrogen bond found in nature. So it's a good rocket propellant and fuels the space shuttle takeoffs and is key to creating radioactive uranium. This substance is not inert and should not be overused. It is not a nutrient. I'm in support of the bills restricting or canceling the use of fluoride. Thank you.
Thank you. Any questions from committee members? Seeing none, thank you. Next, moving on to S1635, an act authorizing pharmacists to provide opioid use disorder treatment. I have Jeffrey Paul Bratberg virtually.
Hello. So greetings and thank you, Chairs Driscoll and Decker, and esteemed members of the Joint Committee on Public Health. The opportunity to speak in support of Senate Bill 1635, an act authorizing pharmacists to provide opioid use disorder treatment. So I'm Jeff Bratberg. I'm a resident of Attleboro, Massachusetts, in Bristol County. I'm a pharmacist, soon to be licensed in Massachusetts, and a professor of pharmacy practice and clinical research at the University of Rhode Island College of Pharmacy, but speaking here on behalf of myself. So when we talk about opioid use disorder treatment, I want to focus on buprenorphine, or the safest and most effective opioid treatment for opioid use disorder, which decreases deaths from opioid use disorder by at least half, but only if people have access to it. So that's the issue with this life-saving therapy. Not enough people who want this medication are getting it, and stark inequities exist between those in and out of treatment. Besides stigma from society, from families, we know that carceral system involvement, housing, employment, transportation, and the color of people's skin are often insurmountable or overlapping barriers to start or remain in care. This applies to all of healthcare. But for buprenorphine, for opioid use disorder treatment, 3 out of 4 people who want treatment and who would benefit from it don't receive it. So we must act with this bill to expand access to treatment initiation and keep people in care. This bill allows pharmacists to do this. So one example of the pharmacist's role in public health is COVID-19. It was an urgent public health problem. We changed policy, and pharmacists stepped up to test folks, vaccinate them, and offer treatments. Policymakers found this compassionate, visible, trusted, and educated public health workforce working in essential locations within proximity to most citizens. This happened, again, because policy barriers were removed and pharmacists were paid for all of these services for COVID-19 response. Massachusetts actually already puts its trust in pharmacists to collaboratively prescribe controlled substances in hospitals and other inpatient facilities to manage a variety of chronic diseases. By giving 1635 a favorable recommendation, community or retail pharmacists can now do the same. We're just expanding the settings where pharmacists can help treat and maintain people on this life-saving therapy. By adding clauses from a companion bill, H.2413, to prevent insurance payment for these services, we know that they will be sustained and expanded across the Commonwealth. Who am I to talk about buprenorphine treatment? I co-authored a New England Journal of Medicine publication on a study in Rhode Island where pharmacists worked with addiction physicians in community pharmacies to start and maintain people on buprenorphine. The patients loved it, the providers loved it, and the pharmacists had this to say. Quote, the improvement we saw in our interactions with patients and to feel their gratefulness for getting help in a way and manner they weren't used to was extremely rewarding. Let pharmacists prescribe addiction medicine in Massachusetts and enable them to be rewarded for helping defeat this public health problem. Thank you.
Thank you very much for your testimony. Any questions from committee members? Seeing none. Thank you. Next we have Tracy Green, virtually. Tracy Green. All right, moving on to S15.
Oh, no, I'm sorry.
Oh, sorry. There you are. Go ahead.
No problem. Okay, great. Thank you. I'm Tracy Green. Thank you so much for the opportunity to consider my testimony in support of 1635. Like many other states, Massachusetts is experiencing too many premature deaths from overdose. But unlike many states, we've responded well with investments like ramping up their access to medications for addiction treatment and the rescue medication Narcan. And thanks to you all, last year we had protection of community drug checking services added to that list. I'm a scientist. I focus on opioid overdose, and it's really quite frustrating to watch evidence-based medications remain inaccessible and inequitably provided. Yet at the same time, to observe readiness and capacity of an underutilized health profession, pharmacists, waiting in the wings to do more for public health and medication treatment. This proposed legislation in 1635 will help continue these positive trends and also empower local pharmacies to meet a public health need, as they have shown to do so every flu season in the midst of an HIV outbreak and in the face of global pandemics. So I'm an epidemiologist at Brown. I co-direct the COBRA on opioids and overdose at Rhode Island Hospital, and I'm professor and director of the Opioid Policy Research Collaborative at Brandeis. I do not speak today on behalf of a representative of any of those institutions, but rather as a Mass resident and scientist. So I have a couple thoughts. First, for 1635, the drug supply is extraordinarily chaotic and toxic, and it introduces enormous uncertainties and harm. So this means we need local supports that can address the risk of local overdose drug risks and provide ready, low barrier entry to treatment. It doesn't get more local than pharmacies. Second, pharmacists can provide medication care to people with opioid use disorder in our communities. And I know this because I led the study that demonstrated it could be done. As my colleague, Dr. Burke, referred to, our published New England Journal of Medicine article in February of 23 found that community pharmacists working collaboratively with remote physicians could be trained to provide induction onto buprenorphine and continue patient care and maintenance pathways. We started 100 patients on pharmacy-based care. And those patients had opioid use disorder and were treated with buprenorphine. 89% of the patients going into the pharmacy care stayed in care 30 days afterwards, compared to 17% of people randomized to usual care. So this study used a model that was like a collaborative pharmacy practice agreement, the same one that is at the crux of 1635. Now we could do this study in Rhode Island, where CPAs permit physicians to collaborate with pharmacists in this way, regardless of where the pharmacist practices. But in Massachusetts, while we have laws on the books that support CPAs, they are overly restrictive. So S1635 is strategic. It closes a loop in a particular way for community pharmacists to provide specific needed services for people with opioid use disorder. Finally, we are no stranger to outbreaks of HIV and Hep C in New England. Medications for opioid use disorder are first-line prevention for the transmission of HIV and other bloodborne infections, and decades of research support this conclusion. And that's because people on medication inject less, they engage in preventive behaviors, and they experience greater quality of life. So 1635 really thoughtfully links the care of opioid use disorder with HIV prevention and care, and these other public health services that pharmacists can and already readily provide. So this bill aligns the enormous strides taken in previous sessions to reduce harm and promote engaging in health, harm reduction treatment, and recovery, and I urge you to pass it today. Thank you.
Thank you very much for your testimony. Any questions from committee members? Seeing none, thank you. Excuse me. We're going to go to S1551, an act establishing naloxone purchase trust fund. And I have Scott Weiner, MD, the naloxone project. Hey, Scott. Welcome.
Thank you. Good afternoon. I'm Scott Weiner, an emergency physician and addiction doctor at Brigham and Women's Hospital, also past president of the Mass College of Emergency Physicians. Thank you so much for allowing me to speak today about this bill. It's S1551 and House 2535, which is an act establishing a naloxone purchase trust fund. You already heard from Representative Schwarz about this before. We're very thankful to him and Representative Donahue for filing this, and also to Senator Keenan as well, who filed this on the Senate side. So we know that naloxone saves lives. We know that the simple act of spraying this in the nose of someone who's having an overdose can make the difference between life and death. And Massachusetts has been amazing with this. We've been on the forefront. We have it available in harm reduction settings. We have it in vending machines in some cities. And then on the other side, we have it in pharmacies where people can now get it without a copay, thanks to the great work that the legislature has done. But there's a huge gap, and that's currently in hospitals. So, you can imagine the most high-risk patient, someone that comes into the hospital after an overdose that survives. Currently in Massachusetts, only about 50% of EDs are putting naloxone in the hands of those people that are leaving the hospital. And this is a huge gap in care because, again, they're the highest risk. The reason for this is basically the insurance processes that don't allow hospitals to bill and get reimbursement for the naloxone that's dispensed in the hospital. So the 50% of those that do just do it at a loss. So we want to fix this. We also know that just writing a prescription to the patient is not sufficient. There's been research that showed that fewer than 1% of people that get a prescription for naloxone from the ED actually get it filled at a pharmacy. So we want to put it in people's hands, especially at these high-risk situations. We looked for inspiration from how we fund children's vaccines, which is from bulk purchasing funds. So what happens is that insurers pay into a fund. We're able to purchase the vaccines. They dispense it to clinics that then give it to kids without any consideration about insurance. It's about herd immunity, right? And this is the same thing with naloxone. I might give it to a patient, but they might use it on a friend or family or loved one. Herd immunity again. So what we want to do is establish a bulk purchasing fund. It's funded by insurers, so it's not funded by the state, not state budget, which would allow us to purchase naloxone in bulk, which we can do for much more cheaply than the list price. Hospitals would then be able to request it from DPH, who dispenses it, and then we hand it out to patients who need it. This is what we call in medicine a no-brainer. We haven't seen any downside to this. We've got a broad coalition that supports this. This will save lives, and we thank you for helping us move this forward.
Thank you. Thank you for explaining that so well. Any questions? Thank you very much.
If I could, for about 10 seconds, MHA submitted written testimony that has some additional language for the legislation that would match with the most recently passed bill at the end of 2024.
Okay.
So just want to draw your attention to that.
Thank you very much.
Okay.
We'll look for that.
Thank you.
Thank you. Next, moving to 1518, an act relative, S1518, an act relative to fluoride in water warnings. I have Elizabeth Paskowski. Hopefully I got that right. Virtually. Elizabeth? Alan McMillan. Alan, welcome.
Thank you. My name is Alan McMillan. I'm here to speaking on the ban of poisoning from our drinking water. I'm in support of all 7 House and Senate bills trying to remove sodium fluoride. Sodium fluoride is a man-made federal class 6.1 toxin that falls between lead and arsenic on the poison scale. The sodium fluoride that is added to Massachusetts water supplies in the mistaken belief that it prevents cavities is a man-made Chinese industrial waste that is a byproduct of the Chinese fertilizer and aluminum industries. We used to put lead in our pipes, finally banned in 1986, lead in our paint, banned in 1977, and lead in our gasoline from 1923 to 1996, until we learned the hard way that doing these things hurt us and our children. This is about the Environmental Protection Agency failing to fulfill its duty to follow the law. The Clean Water Act of 1977 prohibits the mass medication of the public through water supplies for the simple reason that you cannot control the dose of chemical per person. If you drink 1 glass of tap water per day and I drink 8 glasses, I'm getting 8 times the dose of sodium fluoride that you are. Both the American Dental Association and Crest toothpaste websites explain that a topical application to the teeth, i.e. brushing with a fluoride toothpaste, is the most effective way of reducing cavities. So why are we adding Chinese industrial waste to our drinking water? Look at this from an environmental perspective. Less than 2% of artificially fluoridated water is actually consumed by humans. The other 98+% of artificially fluoridated drinking water produced at local water treatment plants is used for flushing toilets, bathing, watering lawns and gardens, used in washing machines and washing cars, etc. Imagine if you were a business owner and only 1.5% of your manufactured product was actually used for its intended purpose. Even a child can see the waste here. Your brain doesn't need fluoride. Your thyroid doesn't need fluoride. Your bones don't need fluoride. The only part of your body that may benefit from fluoride are your teeth, and you can get the fluoride to your teeth through a simple, elegant mechanism. You put it in toothpaste, you brush it on, and you spit it out. Artificially fluoridating water supplies in an attempt to reduce cavities is like using dynamite to swat flies. The side effects far outweigh any benefits. 73% of Massachusetts communities do not artificially fluoridate their water supplies, including Worcester, the second largest city in the Commonwealth, all of Berkshire County, and all of Cape Cod. Artificially fluoridating water supplies is a political decision, not a scientifically proven one. Sodium fluoride is a forever toxin, and adding it to the water we drink is medically, ethically, and morally wrong. Thank you. I am in support of all the issues, all the bills to get rid of fluoride in our drinking water.
Thank you. Any questions from committee? Seeing none. Going back to 1551, S1551, Heather Susi, virtually. Heather?
Hi, yes, can you hear me okay?
Yes, please go ahead.
Great, thank you. Good afternoon. I am writing in strong support of House Bill 2535 and Senate Bill 1551, an act establishing a naloxone purchase trust fund. Since 2015, more than 2,000 people have died every year in Massachusetts from an overdose. That is 6 lives lost every day for nearly a decade. Odds are that each and every person here today is or knows someone who has been personally affected by an opioid overdose. I personally am no exception. For the past 7 years, I have served as an emergency department nurse. I have lost count of the number of lives I've seen taken by opioids. However, I've also seen firsthand the power of naloxone. I've watched patients that were moments from death come back to life within minutes of receiving it. I've heard stories from friends and families of victims of overdose who attribute nasal naloxone to saving the lives of the people that they love. It is well known that people leaving hospitals are particularly vulnerable to experiencing an overdose. Naloxone should be provided to every at-risk individual before leaving a healthcare facility. However, due to the billing complexities that Scott had mentioned before, only about half of hospitals in Massachusetts are actually doing so. This is unacceptable. The ability to survive an accidental overdose should not depend on whether a patient or a hospital can navigate insurance reimbursement. Other community-facing organizations such as homeless shelters, harm reduction centers, and even the MBTA have all recognized the critical importance of making naloxone accessible throughout the community. Hospitals, where our most vulnerable patients receive so much of their care, have a responsibility to do so as well. So by establishing this trust fund, the Commonwealth can leverage bulk purchasing power to obtain naloxone for hospitals at a significantly reduced cost. By negotiating pricing, we could increase the amount of this medication being dispensed at no additional cost to payers or providers. I want to emphasize, this trust fund would allow the Commonwealth to increase the amount of naloxone being dispensed by hospitals significantly at no additional cost to payers or providers. A bulk purchase program would also eliminate the need for billing at the individual level. It would ensure that every patient at any hospital could obtain a dose, regardless of their insurance status or level of coverage. This legislation represents a clear, cost-effective, and equitable step forward in our response to the overdose crisis. I urge you all to please support it. Thank you.
Thank you. Any questions? Seeing none. Next, moving to H.2513, an act to reduce the risk associated with allergic reactions. I have Hunter Gutting. Hunter? S1478. I have Haley Shore. Haley?
Hello, can you hear me?
Yes, please go ahead.
Great, thank you. Good afternoon, and thank you for the opportunity to speak today. My name is Haley Shore. I'm a resident of Boston, and I work for the Best Bees Company. We're a Boston-based business that provides professional beekeeping services across the country. Since our founding in 2010, we've expanded nationally, but we remain headquartered here in Boston, managing nearly 700 beehives within 90 minutes of the city. So we offer some unique positioning here. As we've grown, I've worked to standardize our safety practices, particularly as they relate to working with bees in spaces that are near people. Understandably, as we work with live bees, one area of significant concern for us and our clients is access to epinephrine auto-injectors or EpiPens. My staff don't have known allergies, but they work in highly public areas, including locations like the Rose Kennedy Greenway, where our hives are positioned just feet from public footpaths. While our chosen species of honeybees is generally considered docile, the potential for a member of the public to experience an unexpected sting is not hypothetical, it's a foreseeable risk. Many individuals don't know that they have an allergy to honeybees until their first sting, which leaves a gap in potentially life-saving care. Further, the risk of allergic stings is a risk that's not just associated with proximity to our hives, as honeybees can forage for a distance of up to 5 miles, but individuals have the potential to have an allergic reaction at any time, at any location, for any variety of allergies that they might not know. This bill is aimed at increasing the likelihood that someone nearby will be trained and able to provide life-saving care. Currently, my beekeepers are reimbursed for EpiPens that are prescribed through their personal doctors. However, this approach is a patchwork solution and leaves us with too many gaps. Not all of my staff are able to obtain prescriptions easily, and more critically, EpiPens are tied to their personal use. In an emergency, they may hesitate to assist a member of the public due to concerns around access, liability, authorization, and Best Bees' own internal policies, which are forced to be vague due to the lack of legal protections. Allowing businesses like ours to directly obtain and manage undesignated EpiPens paired with appropriate staff training would provide a simple, cost-effective, and potentially life-saving solution. Similar laws have already been passed in 36 other states, so Massachusetts is well behind the curve here. Epinephrine is extremely safe. It's a fast-acting medication that uses a compound that's already produced within the human body. Adverse reactions to it are exceedingly rare, and the risk of harm when used during a suspected allergic reaction is minimal, especially when compared to the consequences of inaction. I would argue that readily accessible EpiPens are no more dangerous and equally as essential to public health as defibrillators, which can be readily found in many large institutions and government buildings. This is a matter of public safety, preparedness, and common sense. Again, a person may not know they have a severe allergy until their very first reaction occurs, and at that point, they're very likely unprepared. Our staff, along with the staff of places like recreation facilities, sporting areas, and other public spaces, are likely to be in the right place at the right time, but we lack the tools and legal clarity to respond confidently. We're looking to be part of the solution, and we're asking that the Commonwealth support legislation that empowers us to. Thank you so much.
Thank you for your testimony. Any questions from the committee? Seeing none. Thank you. Next, moving to H.2413 an act establishing a special commission on avian influenza, H5N1. I have Charles Kenny, MD, Tri-Town Board of Health. Charles Kenny, MD.
I'm here.
Go ahead.
Okay, thank you. I'm chairman of the Tri-Town Board of Health, which is the combined boards of health of the towns of Lee Lennox and Stockbridge in Berkshire County. The Tri-Town Board of Health oversees the functioning of the Tri-Town Health Department, which is the oldest such shared health department in the Commonwealth. During COVID, at the outset of COVID, the visiting nurse service that served South County towns went bankrupt. And the Tri-Town Health Department stepped up and organized a shared service for those towns to provide the nursing care that was now deficient, and in addition to provide the anticipated vaccination services that we would need, and we continue to do that. I'm also the medical director of that Southern Berkshire Regional Collaborative. Now, I'm fully in support of the avian flu H5N1 bill number 2385 that's before you, because I believe it will provide for the public safety and welfare in our Southern Berkshire towns where currently governmental support is lacking. It's deficient. We brought this to the attention of the Department of Public Health quite a while ago. The department has recently had a report from the Office of Local and Regional Health. It was released in May of 2025, just last month, with respect to emergency preparedness and response. Even though the Commonwealth has given Berkshire County millions of dollars over the last decade, the findings of this local regional health survey are, I'll quote, "Community needs were not met for any of the headline responsibilities under emergency preparedness and response." Now, we need this bill in place to pick up for this deficiency. We have, the towns themselves have put in place their own, using their own funds, rather than all these monies that were intended for it. Using their own funds, they put in place emergency preparedness plans for wildfires and flooding, but we have nothing for the serious kinds of problems like H5N1. And I'm hoping that we don't have, for example, any kind of communication between the Department of Agriculture and the various other departments that would be involved. We know that H5N1 is widespread in the Commonwealth. We know that it infects wild birds. We know that it infects poultry. We know that it infects dairy cattle. We know that it infects humans that are in contact with these dairy cattle and animals that consume sick species. But at the present time, we don't have any directives or any kind of organization for our various boards of health and how to respond to problems that would arise, for example, in our communities because we have, let's say, agritourism, which is a kind of a industry that's brewing where farms are invited to bring to public gatherings pets, animals so that children and adults can pet them. And we don't have any kind of organized way to handle a beginning epidemic. And this needs to be done. And it needs to be recognized that even though there has been a lot of funds given to Berkshire County, there hasn't been the proper oversight to see how those funds were used. So I'm asking you, please, as a stopgap measure, I want you to support this bill so that we can have it in place. And I would hope you would even go further and investigate why all of these monies have not been used to do what they're supposed to do. Thank you very much.
Thank you, Doctor. Thank you for your testimony. Thank you for your service in public health. Any questions from the committee? Seeing none. Next, moving to S1497, an act protecting patient safety regarding non-FDA approved drugs. Lee Rosebush on virtual.
Yes, can you hear me?
Yes, go ahead.
Thank you. Thank you, Committee Chairman, and thank you to those in the committee. I wanted to start off by saying that the Massachusetts Board of Pharmacy, the experts in this area, had a memo and policy position in place that would have in essence enacted S1497, and recently in a 7-to-1 vote actually revoked that policy. I would like to ensure that the continuation of the ability of outsourcing facilities to be able to provide drugs that are life-saving to pharmacies stays in place. Accordingly, I'm here in opposition of S1497. Under current Massachusetts law, federal law, and FDA policy, state licensed pharmacies are permitted to dispense drug products compounded by FDA-registered outsourcing facilities. Accordingly, OFA, which I serve as the chair of, urges the Joint Committee on Public Health to ensure this practice remains permissible when considering any amendments to Massachusetts law. Any amendments that would alter the ability of a state licensed pharmacy to dispense drug product compounded by an FDA-registered outsourcing facility would be contrary to federal law, a 180-degree change in Massachusetts law, and most importantly, any change would harm residents of Massachusetts by compromising patient safety. As an example, currently one of the only suppliers of concentrated albuterol and desmopressin is an outsourcing facility. Without the ability to dispense product from a 503B, hospitals such as Mass Gen would be unable to send pediatric and hemophilia patients home with desmopressin or concentrated albuterol, meaning that Massachusetts patients, including pediatric patients, would be required to increase hospital stays, increasing cost and patient risk instead of sending patients home. Unlike traditional compounding pharmacies, 503B outsourcing facilities operate under rigorous FDA oversight, including risk-based inspections by the FDA and CGMP compliance, the same quality standard that conventional drug manufacturers operate under, ensuring product quality, sterility, and consistency. Accordingly, to ensure that residents of Massachusetts continue to have access to compounded medications such as desmopressin or concentrated albuterol produced under the most robust quality standards, the Joint Committee must reject S1497 or any amendments that would prevent a state licensed pharmacy from dispensing 503B compounded medications. When crafting Section 503B at the federal level, Congress specifically differentiated the terms sold, transferred, dispensing, and resale. Thus, Section 503B of the federal law works to prohibit 503Bs from selling compounded drug products to a traditional wholesaler such as Cardinal or McKesson, who then resells the compounded drug to another downstream entity for administration or dispensing. Further, Section 503 of the Federal Food and Drug Cosmetic Act does define the term wholesale distribution. Specifically, wholesale distribution does not include the purchase or other acquisition by a dispenser, hospital, or other healthcare entity of which for a drug for which use by such dispenser, hospital, or other healthcare entity would be able to use. In addition, Congress's intent to allow physicians and pharmacies to have the ability to dispense human compounded drug products to their patients was articulated by Representative Frank Pallone, who's a Democrat from New Jersey, during the federal House debate. Specifically, he said this gives doctors and hospitals the ability to purchase compounded drugs for their patients made in a facility that is subject to stringent FDA quality standards and oversight. The FDA agrees with Congress's intent to do this and in fact has done so in guidance document. And I would say, unlike the high quality standards set forth under Section 503B, USP standards utilized by 503A standards do not require as many safety checks. For instance, CGMP is not part of USP standards. Nevertheless, we do not want another compounding disaster to occur like the New England Compounding Center catastrophe that occurred here in Massachusetts. That catastrophe sickened hundreds of patients and killed 64 people. Thank you.
Thank you. You're welcome to submit additional testimony. A reminder to everyone else still listening virtually or in person to matthew.murphy@masenate.gov. I have a few day of signups here. Sorry, the writing is a little tough. Chiorren Ruiz, maybe? And then Victoria Martin. Victoria? Then we have I believe we've got online, we have Sarah Rose Salud. Sarah Rose.
Oh, I'm here.
Please go ahead.
Hi, so I'm here in support of the promoting the amputation task force development. So we have a big problem here in Massachusetts that we are the ranked fourth highest in preventable amputations in the U.S. I'm a podiatrist. I work at Mass General Hospital, and I'm part of a limb amputation prevention program here. A lot of the barriers we face here in Massachusetts do relate to legislative problems, including significant limitations in podiatrists' ability to perform certain procedures, as well as coordination with other medical specialties. Right now in the US, not only is diabetes on the rise, but because of advances in medications, diabetic-related complications are also on the rise. So this includes diabetic foot ulcers, which ultimately can result in an amputation. And these amputations not only significantly impact the patient's life and their quality of life, but it also has a significant impact in the cost of healthcare, with more than 4 times an increase in the healthcare costs associated with an amputation as opposed to management of a diabetic foot ulcer. There is significant disparities in this state specifically as compared to other states in the U.S. due to the significant legislative differences in regards to the scope of both podiatry, which is the one specialty that has a focus specifically on diabetic foot ulcers, and limb salvage, as well as their coordination with other specialties, including vascular surgery. Additionally, what this task force could aim to do is work with industry in that there are significant advances in technology where that isn't necessarily adopted within the healthcare system as quickly as it should be to prevent these legs from getting amputated. We know that once someone gets an amputation, they have close to an 80% chance of death within the next 5 years. A lot of this is preventable, and so by saving people's legs, we do have a chance of saving their lives and increasing their lifespan and their quality of life. This bill is supported by the vascular surgery group at our hospital, I apologize, Mass General Hospital, with Anita Dua that should also be testifying as well as the American Diabetes Association, and with well-published data that a multidisciplinary group decreases amputations and increases survival in these high-risk patients. This is a significant gap within the state. Thank you.
Thank you very much for your testimony. Any questions from the committee? Seeing none. How FAM, virtually? HAU FAM?
I'm trying to...
Yes, go ahead.
Yes, hi. Thank you for the opportunity to testify in support of House Bill 2433 and Senate Bill 1508. My name is Hao Pham. I am a board member of the Massachusetts Foot and Ankle Society, a non-profit association that represents podiatrists throughout the Commonwealth. I am a podiatrist. I have worked at Boston Medical Center, a safety net hospital, for 23 years. Many of my patients have diabetes and foot ulcers. I take a team approach to manage ulcers and prevent amputation, involving endocrinologists, podiatrists, wound nurses, infectious disease specialists, vascular surgeons, and supporting staff. We learned many lessons from COVID-19. The pandemic shut down many clinics to stop the spread of COVID-19, which led to patients missing the care they need for their ulcers. Our study at Boston Medical Center showed a decrease in the number of wound care visits during the pandemic, but an increase in the number of foot amputation, 24%, and leg amputation, 15% compared to the year before the pandemic. The number of amputations continued to rise in 2021 and finally returned to pre-pandemic level in 2022. Unfortunately, we do not talk about preventive amputation enough. As such, many vulnerable patients at Boston Medical Center are unaware to what to look for to help them. Studies have shown that diabetes, peripheral artery disease, and infections are the main cause leading to leg amputation. These amputations are preventable through early screening and ongoing care. Lessons learned from COVID-19 indicate that access to care is crucial in preventing amputation. The proposed task force will bring together key stakeholders to outline ways in which we can improve our system of care for preventing amputation. We improve diabetic foot ulcer and peripheral artery disease awareness, two key conditions that led to many amputations. The task force costs little money to convene, but will save patients and the healthcare system a significant money in the future. In conclusion, I respectfully ask that House Bill 2433, Senate Bill 1508 be given a favorable report. Thank you for your condition in this important matter.
Thank you for testifying. Any questions? Seeing none. Melissa Bragg on virtual. Melissa? Melissa Bragg? Can see you, your screen, but I cannot hear you. You might be on mute. Sorry, Melissa.
Can you hear me?
Yeah, we can hear you now. Go ahead.
Okay, sorry. Thank you for the opportunity to speak. So, my name is Melissa Braga. I'm a registered nurse, wellness coach, and Massachusetts resident. I fully support bills S1517, H2548, S1518, H2549, and S1630, H2449. One of the most fundamental principles in toxicology is the margin of safety, the buffer between a dose that is therapeutic and one that causes harm. For fluoride, the margin is alarmingly thin. In public health, a tenfold safety factor is typically required to protect vulnerable populations. And this means the safe exposure level should be 10 times lower than the dose shown to cause harm. However, the U.S. optimal fluoridation level is 0.7 milligrams per liter, and harm, including lowered IQ and dental fluorosis, has been observed at 0.86 milligrams per liter. So with some studies reporting harm at even 0.7, the very level currently used. National Toxicology Program was one of the studies. So that gives us a difference of just 0.16 milligrams per liter, a safety margin of only 1.2 times, far short of the 10-time standard. So if fluoride were regulated with the same safety standards as other substances, the maximum allowable level would need to be closer to 0.08 milligrams per liter, yet we're dosing the public at nearly 10 times that threshold. The National Toxicology Program 2023 review of 74 studies concluded that fluoride exposure at or near 0.7 milligrams per liter impairs neurodevelopment and may reduce IQ in children. There's no adequate margin of safety. According to the CDC and ADA, fluoride's benefits are primarily topical, not systemic. So topically, it strengthens tooth enamel when applied via toothpaste, varnishes, and rinses, not by swallowing it. Mass water fluoridation, therefore, offers no unique benefit that cannot be achieved through direct, safe, and voluntary topical use. So many will say that fluoride is a natural occurring. However, the fluoride used in water treatment is not the natural occurring calcium fluoride. Instead, it's a typically hydrofluorocyanate terephthalic acid, a byproduct of phosphate fertilizer manufacturing. They are not pharmaceutical grade and may contain contaminants like arsenic, lead, and cadmium. In fact, NSF data shows that hydrofluoric acid induces approximately 0.43 ppbs of arsenic into the drinking water, an undisclosed contaminant consumers deserve to know about. Calling it natural is deceptive. Fluoride competes with iodine at the sodium iodine supporter, impairing thyroid hormone production. Lower level exposure has been associated with elevated TSH and hypothyroidism. Approximately 5% of adults are diagnosed with hypothyroidism, and it's rising, especially in women. I know my time is up, but 25% translates, so there's the claim that fluoridation reduces cavities about 25%. So that would be that would be 2 fewer cavities per child. And there's already shown signs of dental fluorosis, about 40.6%, and that's CDC data as well.
Thank you.
So 12, thank you, I appreciate it. I will submit the rest. I appreciate your time.
Thank you. If you could submit the rest to matthew.murphy@masenate.gov.
Thank you, I appreciate it.
Next, we have Elizabeth Peskowski. Elizabeth? Did we lose her? Okay. Is there anyone else we missed in the room that signed up to testify? Anybody online, on virtual, that we missed from our list? I think that's it. This will conclude today's hearing for the Joint Committee on Public Health. Again, you can email matthew.murphy@masenate.gov with any additional testimony or data. All received testimony will be thoroughly reviewed and then considered as the committee makes decisions about the particular bills before us. Thank you for participating with us today. Thank you to the members of the legislature that stayed with us today, and our hearing is adjourned.